This conference will
Combined.
now be recorded.
I guess we're being recorded. Welcome everyone to the first PI coordinator call of 2020. It still bugs me out every time I say 2020. It's just hard to believe that we're already in the next decade. Next slide. So our agenda for today is a whole bunch of updates, and why don't we advance to the next slide and we can start with recruitment. So as of the beginning of the month, we had 286 patients randomized across 35 different sites. So combined continues to be a effort of Herculean proportion. Strong work to all of the sites that have randomized patients during the crazy time of year of December and early January, including Golisano, our site at UNC, Cardinal Glennon, Riley, Vermont, and Levine. And until further notice, our mantra is keep recruiting, full steam ahead. We have had ongoing discussions with PCORI, our funder, about a no-cost extension. I am reasonably optimistic that we will get the green light to continue recruiting through the fall, but have not heard any final word. But as soon as we hear, we will pass on the news to you all. But until then, let's keep doing our best to recruit and fill this study as much as possible. Next slide. So again, this is our monthly recruitment, and we have 139 patients to go to reach our original goal of 425 participants. And fortunately, the gap is narrowing each month. This is actually the first time in years where I had a little bit of a notion that the end is actually within sight, and that if we don't reach the finish line, we will get quite close. So that is I think encouraging. As long as we all sort of buckle down, keep our nose to the pavement, and are aware of all of our patients that are starting anti-TNF, and do our darndest to approach them with a convincing recruitment pitch. Next slide. This just shows our recruitment by site. Cincinnati is our lead site, and Children's Hospital of the King's Daughter, UNC, Riley, Stanford, Oklahoma are certainly all contenders. And it's nice to see both the height as well as the width of this graph. It really does take quite a large village to pull off a project of this magnitude. Next slide. We'll move on to a myriad of general study updates. The first is a reminder that the spring community conference will be in Orlando this year. And as always, we will have a combined lunch. This time, the combined lunch will be on Friday, April 3rd. It won't cost you anything extra, so please, if you are at the community conference, plan to join us for the lunch. We'll make sure that it is both fun, entertaining, and informative. And if you are not coming to community conference, we will probably do what we always do, which is distill the most important concepts presented and repurpose them on a webinar a week or two after community conference. So don't worry, you won't miss out if you're not attending the conference, but if you are attending, please join us for great fun. Next slide. I wanted to talk a little bit about adverse event reporting, and we're a little concerned about some sites possibly under-identifying and under-reporting adverse events. You could see on the chart to the right that, on average, sites are identifying and reporting one adverse event per subject, although many sites have much lower reported adverse event rates. And while it's possible that those patients are healthier or just have had fewer adverse events, it may also be that some of those sites have let their guard down a little bit and are not questioning families or working with the primary GI providers to identify adverse events that are recurring. Janine, our wonderful study monitor, has raised the issue to many sites about the possibility of sort of underreporting. And we have our twice yearly meetings with the Data Safety and Monitoring Board, and the variation in event rates between sites has been a matter that the DSMB has brought to our attention as well. Next slides. So we'll talk a little bit about adverse events. As you all know, we baked into the protocol the fact that we don't require sites to report adverse events that are definitely related to Crohn's disease or part and parcel with Crohn's disease or Crohn's disease flares. In many ways, that indicates a patient who's not responding to treatment and patients who move on to ultimately meet one of our loss of response components of the primary endpoint. And so things like abdominal pain, fatigue, abdominal tenderness on exam, diarrhea, nausea, vomiting, any of that stuff that the site clinician, the site PI feels, this is just a typical Crohn's flare. Again, no reason to report those as AEs. This is a pragmatic trial, and we wanted to ease the reporting burden at your sites. But if the site is unsure or questions whether or not some nonspecific symptoms are due to Crohn's disease or some other trigger, go ahead and report them. If there's something that's unusual about the symptoms or uncharacteristic of that patient's typical Crohn's flares or of greater severity, then go ahead and report as an adverse event. But again, if this is just a typical Crohn's flare for this patient, then we designed the protocol to spare you the paperwork. Next slide. Any non-Crohn's disease health events should be reported as adverse events. And so this time of year, everyone has the cold or flu and, cough, nasal congestion, body aches, sore throats. All of these should be reported as adverse events. Things that are probably unrelated to combined treatments, things like broken bones, joint pains, mental health issues like depression and anxiety, conjunctivitis, nosebleeds, whatever it is. Again, these are adverse events because they happened to a patient while he or she was enrolled in the study. The only exception to this is pre-existing conditions that you've already documented at the time that the patient was enrolled. And we've got that form for pre-existing conditions, and there's a reason for that. That's to spare you the need to report these things as adverse events if the frequency and severity are unchanged. And so again, if this is a patient with, cold or winter related asthma, and they have a flare of their asthma every January, and they have an asthma flare next week, that's characteristic of their typical asthma flares, and you've already recorded asthma as a pre-existing condition, no need to report that as an adverse event. But if usually their flares are managed at home and this time they needed to be admitted to the hospital, well, that's a change in severity and should be reported as an adverse event. And so we just ask for the study teams to work together and work with the clinicians and nurses who are providing the clinical care to participants to develop a system to, identify whether adverse events have happened. Usually that's a good history during a clinical encounter, where you're updating the review of systems, or gathering information about the intercurrent history. If the primary team finds out that something's going on, it should probably be documented in the notes, and maybe a quick heads up to the study team to record that as an AE. It's helpful for the study teams to periodically scan through clinic notes. If the study team is talking to the family, either distributing a PRO form or collecting a biosample or making a phone call after a study medication shipment was sent, it's a good opportunity to assess for adverse events as well. As always, if you're unsure about whether to report something as an adverse event or not, contact us and we can guide you. Any questions about adverse events before we move on to the remainder of our session today? I'll give folks a chance to unmute if they're muted. You can always put something into the chat box as well. All right, hearing nothing about adverse events, let's move to the next slide. And Anne, I think this may be where you take over.
It is, but Mike, we have a question here. Why would a cold or flu be an adverse event?
Because it is a health event that happened to a patient after enrollment in the trial. That's the definition of a adverse event, or at least a paraphrased definition of the of an adverse event in our protocol. Something like a cold or flu is of particular interest to us because it's a infection, and one of the things that we want to know is, do patients who are receiving methotrexate have more infections or more severe infections than patients who are in the placebo arm? And so infections in this particular trial are particularly relevant. In many ways, that's the quote cost of methotrexate that will need to be weighed against whatever benefits we observe in improving response. All right, next slide, and Anne, I think it's your turn.
Sure. So these next sections here are a compilation of our frequently asked questions that we've been getting these past few months here. So I want to touch upon the biosample collection. We get a lot of questions about when we should be collecting these. If a patient is off study medication, do we collect the second one? The answer to that is always yes, but go ahead and email your questions if you are ever wondering when or what should be done with these research samples. So one of the things that we've been noticing is that if you're collecting your samples on Monday through Thursday, please just ship these tubes directly to the biobank. Don't pre-process them. There isn't anything that you have to do except just invert the tube maybe 5 or 6 times up and down, let it sit for 30 minutes, and then just ship them directly to the biobank. As most of you know, the minor lab is no longer collecting the small purple top tubes, the 4 milliliter tubes at visit 3. So this is for any of your new patients that are coming along. They are still collecting their visit 9 samples if the patient had a visit 3 sample and the minor lab tubes were collected. Please go ahead and repeat that at visit 9 as well. Next slide. Okay, some of your collection tips. Please check your supplies. So I noticed that an email went out this morning to warn people of expiring tubes and to please check. So you should get in the habit of checking your tubes at least a week before you're expected to use them. Make sure that you check the expiration date on the tubes and not the boxes, because they tend to get mixed up. So we're just going by what is on the tube itself. Contact Catalina if you need any of the larger purple top tubes or the gold top tubes, and you're going to contact Kimberly Jackson if you need any of the smaller purple top tubes. If your site does not have access to a centrifuge, please do not collect samples on Friday or Saturday. So these, if they're collected on Friday or Saturday, they do require pre-processing. It does require a centrifuge. So if you don't have this available to you, then this would just be a waste of a sample. Also review the site lab manual before collection. I know that most of you have been doing this for several years now, but it could be many months in between collections. So just remind yourself of what needs to be done by reviewing that site lab manual. And it's also a really good tip to either bring out the page that is of question and hand that to your lab technician or to the nurse who is going to be getting the collection. But if you share that manual with your other team members, it will just make the process go much smoother. Also be aware of any of the holiday closures or potential weather events that could affect the UNC biospecimen lab. So we have tornadoes, we have hurricanes, but mostly we had a couple of specimens that were sent over the holidays, and the lab was closed for almost 2 weeks over the holidays, and that info got shared in an email earlier, but some of you missed that, and samples were sent to the lab when they were closed, and although they did process them, it's likely that those are not good samples. So just be aware of when that lab is going to be open. And of course, if you ever have any questions, just contact myself, Catalina, and we'll be able to steer you in the right direction. Next slide. Okay, next up is who's eligible for year 3. So we've been getting a good number of patients agreeing to continue into their 3rd year of follow-up. And so all patients are eligible if they have not yet met a study outcome. So they don't have to be on study medication. If they stop the medication for non-medical reasons, they are eligible to continue into year 3. And then any patient who is on study medication usually indicates that they have not met an outcome, and they are also eligible for year 3. So you're going to be asking your patients around visit 9 or visit 10 at the latest if they're willing to reconsent for another year. It's just doing exactly what they have been doing in the past. We won't have any other research or lab collections during that final year, but it will just be your typical follow-up questions that we'll be monitoring. Next slide. And we have a lot of patients that are completing now. They've completed their 2 years of follow-up, and so there is a patient completion checklist that's available on the SharePoint site, or you can contact either of us and we're happy to send that to you. But it's a really nice checklist to be able to go through and go through your patient and ensure that all pieces are there. And then once you have everything done, you can just kind of close the books on that patient and know that everything's been completed. So if the patient has not agreed to continue for the 3rd year, you're going to go ahead and complete that visit 10 CRF. discontinue all the study medications by completing the dose change, and then fill out the completion CRF to indicate that the patient has completed the study. So patients who complete the study and are still on study medication, they are eligible to be unblinded. And so just go ahead and send me an email with the information. I'll take a look at the documentation for your last visit, ensure everything's completed, and then we'll arrange for the pharmacy to unblind you. Next slide. Okay, what to do if your patient misses the last study visit? This is more common than we thought would happen. So they've, everything's been wonderful. They're ready to finish, and visit 10, it's a no-show or something else happens. So if you're able to get that patient to come back in within a reasonable time frame, say about 6 to 8 weeks after the visit window closes, count this as your last study visit. Log it as a visit deviation, mark the patient as complete, and you will be paid for the final visit. On the next slide, another scenario that we often see is that they're not able to get rescheduled within a certain amount of time. So please see if you can contact the family, call them, see if you can get any information over the telephone to confirm and record any outcomes or adverse events, or do as much as possible over the telephone. You can email the PROs and have them return those to you. And then you can mark the patient as complete. Next slide. If you're not able to connect with a patient and they just are not returning any of your phone calls, go ahead and complete the early termination form with the date of the last contact, last time that you knew that there was not an outcome. And if any outcomes were met, please ensure that the dates and outcomes are recorded. So I think most of you have already seen the outcome certification form. This needs to be completed with every study outcome that happens. So you can either be proactive and fill that out whenever you know that a patient has met a study outcome, or email me and I'll send it your way as well. Next slide.
Hey, Ann, it's Mike. If I can just interject. We and you guys know when that final study visit is going to happen 2 years in advance. In other words, when the patient is randomized into Combine. So this is a really good opportunity to, keep track of your patients with all of the study visits. If they're not scheduled for a clinic visit during the window where a study visit should occur, be aware of that in advance. Contact your schedulers or nurses or whoever helps with that and get the patient scheduled. Again, these are high-risk patients with Crohn's disease who started on an anti-TNF, and for clinical reasons, we want to follow them closely. This is particularly important with that final study visit. We know far in advance when that final study visit should happen. We shouldn't be surprised, the last visit window is closed and the patient didn't come in. We've got 3, 6, 9 months to anticipate that. So please sort of do a little bit of advanced planning to prevent problems down the line. All right, Ann, back to you.
Absolutely. And so just quickly, reminder about the deviation logs. So these are automated, will come out the first of the month. Please only respond to the current email that you get. So don't link it up, don't use an earlier email, because the system is very sensitive and it only wants you to use the current month's email. So there are times when you are definitely proactive and going in at the first of the month and doing this before you even receive the email. And what happens is that information gets put onto the prior month's log, which is all, it's hitting the deviation log. That's great. But then you're going to be getting these reminders because the system doesn't think that you responded to the current month. So if that happens, again, just send me an email and we'll get that cleaned up on the back end. Next slide. Okay, don't respond to the earlier link. They're sent out on the 1st of the month, must be completed by the 15th. You'll get an email from Janine if you've missed getting these out. So please don't ignore her emails or our emails, and it takes a matter of just a few minutes to complete this on a monthly basis. So thank you for your diligence in doing this. Next slide. And that's all we have for today. Do we have any questions about patients completing or how to mark them as completed versus they are not being withdrawn from the study? Any questions about the biosamples or anything at all? Okay, be sure to email us or call us if you do have any questions. And have a great week, everyone.
Thanks, everybody.